So guys, actually two of the most difficult things that I've found with pediatrics is that, and these two things, they usually throw a lot of us off and make peds look so difficult. I'm not saying it's easy, but it just makes it so difficult. So the first thing is the fact that kids cannot really verbalize their signs and their symptoms, how they are feeling. They can't tell you. It's one. Number two, a kid can present with vomiting, and yet they've got otitis media. Or they can present with vomiting, and yet they have got UTI, or they've got meningitis. They can present with loose stools, and yet they've got bronchopneumonia. So those are some of the things. So it's very difficult. So they can present with anything. They can present with a headache, especially if they can verbalize. Maybe they are 10 years, 9 years. They can say they've got a headache only to find out they've got UTI. So, and I've seen that a lot. And yeah, so that's why many pediatricians, they don't want these kiddies to receive any antiemetic, because when you give them an antiemetic, you're not really addressing the situation, and you will mask the symptoms, things like that. So the presentation here with the PDAs, like your left to right shunt lesions. So the presentation, like in the first, like I said, in the first 1 to 2 weeks, in the first one day to 2 weeks, this is how they will present most likely. But if they go home and all of that, what I was saying is, at 6 weeks when they come, you need to ask the mother about the feeding. So feeding in newborns is an exercise. It's like someone who's got heart failure, and then they walk up a flight of stairs. Then when they get to the very last step, they're short of breath. They have that and that and that and that. They are tired. So that is the same as a kid when they are feeding. Feeding is really an exercise for them. So these kiddies will present with feeding problems. Like some of them will refuse to feed. Some will interrupt the feed. They will suck and then interrupt, stop feeding even before they are satisfied. They will some of them will like I said, they will refuse to feed, interrupted feeding, and also they will fail to thrive because they're not getting enough. So they will failure to thrive. So they won't be picking up weight as expected, and they will have shortness of breath. If they come very late, they might have chest deformity like pectus carinatum. They might have recurrent chest infections. They might have and the shortness of breath in children, the way you pick it up is they will have nasal flaring. They will use accessory muscles to breathe, like intercostal. They might have recessions, subcostal recessions, infraclavicular recessions, intercostal recessions, things like that. And they might also just present with the features of CCF. They might present in failure. So they might have swollen legs. They might have splenomegaly, and all of that. So generally, this is how these kids will present. So the feeding becomes very crucial here. And after you have assessed them for that, and obviously what you will just know that this child is acyanotic, and they've got sets that are not, they've got sets that are not improving on oxygen, and they've got one of these or all of these features, and then you think that, okay, they might be having a heart lesion. So your investigation here will be chest x-ray to see if they've got any lung pathology like a pneumonia, to see if they've got any cardiomegaly, to see if they've got any pulmonary edema. So that's how your chest x-ray will help you. And then you can do an ECG on them. Then you can do blood. How will blood help us? Like I said, a kid can be short of breath or refusing to feed, whatever, not because they've got maybe even a cardiac problem, but because they've got other problems as well. Like they might be hypoglycemic, they might have metabolic problems, acidosis, alkalosis. They might have so you need your FBC, your UNE. You need to do like sort of like a septic workup for them. Like I said, a kid can present with shortness of breath, and yet they've got other things as well. So you want to rule out infection as well, because you don't. It's not impossible to have a cardiac lesion superimposed by some kind of infection, chest infection, UTI, whatever, and your septic markers will help you with that. You also need to check their temperature there as well, because if you've got a high temperature and then just child would need to be started on antibiotics, and if your bloods come back all normal, then you can stop the antibiotics. You rather give antibiotics and stop when the septic markers are normal if you are in doubt. So you need to check their blood sugar. Urine dipstick, check for a UTI, because these are the things that you can still treat while you are transferring the child. Like I'm saying, it's not impossible to have an infection on top of a cardiac lesion. You don't want to miss that. You don't want to miss that. And then another thing that you want to do, you want to refer this patient. When I speak to the PEDS people, because this kid needs an echo, and they need to decide what kind of a lesion, because clinically you cannot pick up which lesion. You will just have a differential. So they will tell you which lesion the child is having, or even if it's a mix or whatever the case may be. So that's that. Okay, so let's do now acyanotic conditions with a normal pulmonary blood flow. So what happens then? Here you have these are obstructive lesions. These are obstructive lesions, which are coarctation of the aorta, AS, PS, aortic stenosis or pulmonary stenosis. So these are the main ones. So in these lesions, you have a heart. So basically, you have obstruction. Your blood is not being pumped the way it's supposed to be. So, like for instance, with an AS, so you've got your aortic arc there. You've got your aorta with your aortic arc. So you've got a valve there that is stenotic. So it's not allowing a full ejection of the blood. So which means, like for instance, if your blood, you are supposed to pump about 40 mils of blood as a kiddie every minute, for instance, and then 10 mils of that blood remains in the heart. That 10 mils, if every time you eject you remain with 10 mils, that 10 mils will remain up until you start dilating your left ventricle because of that stenosis there. These kiddies are usually asymptomatic. They don't have these because that the reason why they are asymptomatic is because that 30 mils of blood, for example, is enough to it supplies the body, and the tissues are able to function, they're able to metabolize with that 30, so they don't become symptomatic. But eventually they will become symptomatic, because the more you get stasis of the blood here, this ventricle will dilate up until it becomes dilated and becomes floppy. And yeah, so the same thing applies with the PS. Same thing applies. You are not able to eject all your blood into the lungs, so some of the blood remains here up until it becomes floppy like that. So when they start, they are asymptomatic, these ones asymptomatic, and these are the lesions that can even be picked up in even when the child is like old, especially the coarctation of the aorta. So it can be asymptomatic or just an incidental murmur, as they say. So the approach is still the same: do chest x-ray, do ECG, do bloods, and get them to do an echo, and they will tell you exactly what lesion is there. So like I was saying, that with kiddies, the difficult thing with them is that they present like the way they present is like it's so like non-specific. Like vomiting in a kid, it's gonna make you to do a head-to-toe examination. Diarrhea is gonna make you to do a head-to-toe, and we know like head-to-toe, like meaning even the ENT exam, the tonsils, the ears must be examined, and all of that, because normally they will present with non-specific symptoms. And that's why if there's a place where bloods are done, is pediatrics, because you look for everything there every time. So it's like someone who's got fits for the first time. Hopefully you're gonna do fits for the first time in children, and see how that goes. Yeah.